Hello everybody, this is James and today I want us to learn about the causes of an elevated mean corpuscular volume or MCV. This is when your red blood cell size is larger than usual. We term it macrocytosis. First, take a look at the medical mnemonic. Alright, so an MCV is simply a measure of the average volume of red blood cell corpuscle. Mathematically, we can say this is the hematocrit multiplied by 10 divided by the red blood cell in cubic millimeter. So the hematocrit is the ratio of the red blood cell volume to the total volume of blood. In other words, if this is a test tube with blood in a centrifuge, then what will happen is that the red blood cells will be pushed to the bottom, the white buffy coat will be there, and of course the plasma we would also see over there. So the hematocrit is the ratio of the red blood cells that we have to the total volume of the blood. So assuming we have a patient who is normal, okay, with a hematocrit of say 40% and a red blood cell count of say 5 RBC per cubic millimeter, then we could do the calculation as 40 multiplied by 10 divided by 5, and we get 80. And this is a normal MCV, that is 80 femtoliter. The normal MCV is between about 76 to about 100 femtoliter. Now we get back to the causes. So hypothyroidism. Thyroid hormones may regulate the synthesis of cholesterol, its transport, and even its clearance. So obviously this lipidemia is a non-clinical entity of hypothyroidism, and in fact there is an association of cardiovascular events in hypothyroidism as a result of that. This lipidemia is in fact an indication for a thyroid function test. So the excessive lipids that accumulate in hypothyroidism are deposited on the red blood cell membrane, which gives it a bigger appearance, hence an elevated MCV. Now in hemolysis or in a post-hemorrhagic event, the body may increase the production of reticulocytes that are immature red blood cells, however, are larger than mature red blood cells, and this influences the MCV levels. Alcohol. The chronic abuse of alcohol may predispose the bone marrow as well as the red blood cell membrane to a direct toxicity from the alcohol. The bone marrow may be suppressed. In the metabolic processing of alcohol by the liver, thiamine, niacin, as well as other vitamins are used, which may deplete the levels of these elements. Note also that folate and B12 deficiency may also be encountered as part of alcoholic malnutrition. Folate and B12 are necessary for DNA synthesis, which leads to a growth of cytoplasm in a non-dividing cell, a megaloblastic cell. Liver diseases may also show an elevated MCV, and this is due to the deposition of cholesterol and phospholipids on the red blood cell membrane. The spleen is a place for the removal of lipids from red blood cells in maturation, hence splenectomy may also elevate the MCVs. Alright, so folate deficiency or vitamin B12 deficiency may also cause macrocytosis, in other words, elevated MCV, and this is true impaired DNA synthesis. Let's take a look at this diagram. So we have folic acid right there, which is found in fortified foods. Folic acid is converted into dihydrofolate with the help of the enzyme dihydrofolate reductase. That's the enzyme. DHF is subsequently converted into tetrahydrofolate, which is the natural folate. And after that, there is formation of two other substances, one of them being 5,10-methylene THF. This is the substance we need to make DNA because the buildup of nucleic acids are done from this substance 5,10-methylene THF. So we need this substance to be able to build DNA so that we can make the red blood cells. We also need vitamin B12 in this final pathway to make this L5-methylfolate, and this is actually the active circulating folate. You can notice that it has a methyl group, which is a donor, serves as a donor. And why do I call it a donor? It's a donor because vitamin B12 is necessary to convert homocysteines into methionine with the help of the enzyme methionine synthase. But B12 is a coenzyme and it's in the form of methylcobalamin. Okay, so methylcobalamin gets that donation from L5-methylfolate to help with this important reaction. You should also remember that the drug methotrexate would block the enzyme dehydrofolate reductase, and so using this drug can also lead to a megaloblastic anemia. In short, what happens is that there is less DNA synthesis, less nucleic acids, less DNA synthesis, and that will lead to the cytoplasm of the cell growing whilst the cell itself is not dividing, and the cell achieves that megaloblastic picture or anemia. These plastic changes in erythroid precursors, DNA damage, and ineffective hematopoiesis are among the reasons why myelodysplasia, myeloproliferative disorders, and multiple myeloma may present with an elevated MCV. Cytotoxic drugs can cause megaloblastic anemia, and you do recall from biology that there are bases such as purine and pyrimidine that forms nucleotides in DNA and RNA. Inhibiting these bases with drugs such as mercaptopurine or 5-fluorouracil may lead to megaloblastic anemia. Other drugs that may cause a similar impairment include folate blockers such as methotrexate, hydroxyurea, which is used in occlusive crisis of sickle cell, and a reverse transcriptase inhibitor such as zidovudine, which is used in HIV treatment. So an elevated MCV has been used to assess drug compliance in patients taking zidovudine, for example. Vitamin B12 deficiency, just like folate, would also lead to an elevated MCV through an impaired DNA synthesis. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.